Good morning, the provost, ably represented by Professor Grady, the Dean, Faculty of Informatics, Professor FBI Shola, the Director, CCTRIS, Professor Widi Afolabi, and the Deputy Director, Architect Professor Obanani Balu, other professors and faculty students here represented. Please permit me to stand on the very well protocol. I'm honored to read the citation of Dr. Lisa Echan. Please can you be upstanding while I read your citation? Thank you. Dr. Lisa Echan is Professor of Medical Social Science and the Director of the Ryan Family Center for Global Primary Care at the Avery Institute for Global Health at the Northwestern University Cambridge School of Medicine. With a background in medicine and HIV, Dr. Heshan is an expert on implementation research, improvement science, and patient-centered outcome research. She actively applies these methodologies to improve the quality and equity of care in resource-limited settings, addressing areas such as primary care, healthy aging, non-communicable diseases, and maternal and child care. In our ongoing work in Nigeria, Dr. Heshan collaborates with the University of Lagos to improve the quality of care for older individuals in primary health care settings. Additionally, she partners with the University of Abuja to improve hypertension care in Nigeria. Our research initiatives encompass studying Nigeria's national strategy to reduce dietary salt intake, building capacity in implementation research, increasing HIV testing and retention among young individuals, and improving the quality of care of newborns. Dr. Echan is actively involved in mentoring numerous students and faculty and Saudi one, and including those from the University of Lagos and the University of Abuja. She has a prolific publication record and participates in various global initiatives focused on achieving universal health coverage and advancing the health-related SDGs. Please do a warm welcome. I'd like to warmly welcome Dr. Lisa Echan at the University of National.
Morning. I want to first and most formally thank the wonderful invitation to come talk at the Center for Clinical Trials Research and Implementation Science. I had the absolute honor of actually reporting a sort of a welcoming video for when this was first started, and it's just fantastic to actually see it now in person and in action. I want to thank, first of all, the Vice Provost, as well as the Dean of Medicine. I've sort of been on, I think, calls and emails, but never actually met in person. Equally, really, very, very warm thank you to the Director of CCTRIS, Professor Afolabi, my colleague and the Vice Director for CCTRIS, Dr. Balaban, as well as the professors, students, and other faculty and staff that are here. Northwestern University has a long history of collaboration with University of Lagos, the premier and preferred university in Nigeria. This is, however, my first time here physically, and I'm just absolutely delighted to be able to meet people and to work. I've been asked to give a lecture on implementation research, and this could be something that could be sort of a 1 hour beginning. It could be a 3 hour workshop, or it could actually be an entire course. So I'm going to try to take you sort of on an overview And why I think it's such an important tool and why I'm so excited that this center not only has implementation science in its name, but actually is absolutely committed to this work. There we go. So the reason why I became involved in implementation science, I'm originally an HIV physician, and I actually had the honor of working here in Nigeria with APIN many years ago, potentially before some of you were born, to really sort of understand where were there gaps in what we do work in terms of HIV treatment and what was actually available. I had that originally from a quality improvement background. But recognize that to reach scale and to really rapidly accelerate change, we needed to bring other methodology. And that's where I think implementation research is really important. And the problem that's it's already been talked about is this gap between what we know works and the effectiveness that has of treatments that have been developed over the last century and how we get this to everybody everywhere with quality. So for example, initial studies that were done in animals and labs show that antiretroviral therapy can actually suppress HIV. From there, we then moved into what we call phase 2 and phase 3 in effectiveness trials, which showed that antiretroviral therapy can actually prevent mother-to-child transmission. And not only that, but when you do a very tightly controlled study in clinics, it still works. But we still need to know sort of how to make that happen in other settings. So, for example, now we know that effective prevention of mother-to-child transmission will work, that amlodipine will reduce hypertension, and that washing hands will reduce the risk of infection. And we've actually known that since around the 1700s. But we still see HIV transmission to babies. We still see morbidity and mortality from hypertension, and we still see hospital-associated infections. And so the answer is, how can we actually make this work? So there's still a lot of very important work that's happening to develop what we call evidence-based interventions, vaccines that prevent infection, blood pressure medications that will lower blood pressure. But the problem is that often these are not implemented at all, or when they are actually implemented, they're not done well, not with quality or what we call fidelity. They're not implemented equitably. Only some people get them, but not other people. Or they're not implemented or scaled effectively. And implementation research will give you the tools to figure out why and how to make this happen. So why do we need to do this now? Why is there such a demand for it? So a couple of years ago, there were 3 studies that came out that were very broadly done at World Bank, WHO, Lancet, that showed this enormous gap in quality. And at the same time, there was a big demand for universal health coverage. What we know is that universal health coverage without quality is not going to get us to where we need to be. And so it's really bringing in not just implementation, but implementation with quality. That's what we needed. And this is really a huge problem because when we think about access, which is the thing that we really focused on a lot, there's still about 3.6 million people who die because they don't have access to what we know works. But equally important, and even more so now, is that 5 million are estimated to die because of poor quality. So we need to bring those 2 pieces together. And not only that, if you're talking to your Ministry of Finance, who might be interested in that, you can tell them that it's $6 billion in economic welfare that gets lost per year. And this, you can't really point the finger in any particular specialty. You can't say, oh, we're doing better, but only if the cardiologist did better, or only if the OBGYN did better. The answer is that poor quality is actually a cause of death across no matter what area we look in. And so this is something that I call becoming context agnostic, meaning that you can work on this no matter where you are working. Now, this is also very important when we think about equity because the worst quality of care is actually found often among the poorest people. This is, you can see the dark blue circles here. Those are the poorest, and you can see that often they are the furthest to the left, which is the proportion that's getting the lowest quality care, the lowest percentage of the things that we know work. So why do we care about quality? Well, quality is not actually a luxury, but it's a necessity and it's also a right. We know that access to poor quality services only costs money and uses resources. It doesn't actually improve your health. And equally importantly, it costs lives. And we learned this first and foremost in HIV, because if you give the wrong treatment, it not only doesn't help, it will actually ultimately hurt. In OBGYN, another sort of important thing where the timeliness of the care matters as well as the quality. It's also an enormous waste of resources. So we either underuse or we incorrect use, but we also overuse it. And it also damages the trust of people coming to the healthcare system to come and get what they need. And finally, if we learn nothing else from COVID, is that health security is really dependent very much on this trust and requires high quality frontline services. So can we change? That's a big question. We know that not many people, or probably no one wants to deliver poor quality care, but many people will. I've never met a provider who wakes up and says, today I'd like to deliver bad care. But a lot of people say, well, today the care I'm giving is not going to be good because I don't have the resources or the knowledge or the ability. Poor quality is therefore not necessarily something we point the finger at an individual, but it really has to do with what are the systems that we need to actually change. And for that, we need some of the resources, the stuff, the staff, the space, but those are necessary, but I would argue not sufficient. And that's where implementation research can help. And we need to think about how to go beyond traditional quality improvement, which usually focuses more locally. And so when we think about it, the traditional research is again this idea about, oops, sorry about that. What happens when you give me technology? Okay. So when we think about traditional research, this is here. So again, very, very important. We wouldn't have had COVID vaccines. We wouldn't have had effective antiviral therapy without this work. But what we really need to be thinking about is how do we actually get this into practice? So this is traditional role of quality improvement. It's local knowledge, local change. And where we're going to be talking about for the rest of the time is when we talk about implementation research, which is getting these things into practice and often does local change, but also generalizable knowledge. So what exactly is implementation research? So like many new areas of science, we'd like to sort of make ourselves sound fancy, as if sort of this is, very jargony. So I'm gonna start first with sort of thinking a little bit about it. I'll give you the technical terms, and then I'll give you what I think is a better way of thinking about it. So again, what we need to do is we need to think about how we're going to improve quality better. So we need to start thinking about these health system options, the delivery of care, the value and the trust, and most importantly, how it needs to adapt to changing population needs. And again, if COVID taught us nothing else, it's that we have to be able to change and to adapt. So the basic concept of implementation science and research is that we have these evidence-based interventions, right? So for example, I'm doing work with NEST 360 with a number of faculty here at Lagos University. And we know that CPAP for small and sick newborn care really works well. But we know that it's not happening in many places with quality. And so we're seeing a lot of neonatal deaths. The implementation research is designed to figure out how to actually bridge that gap. How do we get from what we know works to actually seeing the effect we know? So here's the fancy terminology. Every day is the use of strategies to adopt and integrate evidence-based health intervention and change practice patterns. So when a new vaccine comes into place, what is it that the providers are doing? What is it the managers are doing? Now, implementation, Implementation research evaluates the use of these strategies. What's the best thing that we need to be able to do to actually get these effective evidence-based interventions into practice? And I'll talk a lot about these strategies and how we choose them. Implementation science is the study of the methods. So it's all these things that I'm going to talk about, the frameworks and how we actually analyze, that is that. And then implementation research is actually using it in research. And then you'll see that for those of you that do quality improvement, that a lot of these strategies, there is indeed overlap. But again, implementation research is trying to create generalizable knowledge that's going to accelerate this change. But I actually prefer this. This is a very good paper by Curran, which is basically the innovation or the evidence base, the new vaccine, the new blood pressure treatment is the thing. So keep that in mind. So we want to do, effectiveness research says, does the thing work? If I give you the vaccine, will it protect you? Implementation research says, how do we best help people or places or practices do the thing? Doesn't matter what the thing is. Implementation strategies are all the stuff we do, the training, the incentive, value. So again, effectiveness research, you mostly are interested in the intervention, your health outcomes. Did amlodipine reduce your blood pressure? Did CPAP actually save newborn lives? And you might look a little bit at the system. How well did it work to support the implementation? Implementation research, we switch that. It's because we're working with things that have already been shown to be effective. So instead, we are focusing mostly on the system. And then we might also look a little bit at effectiveness. You know, if it worked in Nigeria, is it going to work in Liberia? If it worked in Nigeria, is it going to work in Chicago? While we're doing these studies, we often use implementation data to adapt our strategies during the study. So for example, if I'm trying to get people to use something called the Safe Childbirth Checklist, which is something that's been used in obstetrics to reduce to improve maternal and neonatal outcomes. And I think coaching is a good thing to do. But after about a month, nobody's using the checklist. I don't keep on doing that. I actually go back and say, well, what other strategies do I need to do to be able to do that? Now, if you're doing a drug A versus drug B, you're not supposed to mess around with that. But in implementation science, we often do. So when you're sort of thinking about it, I find this a very helpful sort of roadmap, or sort of a subway map. If those of you who've been in the UK, mind the gap, we're trying to bridge it. Is you sort of say, okay, I'm interested in this. Has it actually been proven to have efficacy? The answer sometimes is no. Then you need to go to efficacy research. If it has, you want to know, has it been shown to be effective? The answer is no, you go to effectiveness research. But if it's partially or yes, that's where we're living. And we're going to be really sort of talking about this green area where we think we have effectiveness or we know, and we're also interested therefore in how to get it into place. So when we start thinking about things, and this is the question that we're really trying to answer, is if something is not working in the real world or it's not working with quality, you have to ask yourself a couple of questions. Is it the wrong intervention? Is it the right intervention, but it was not actually being delivered with fidelity? Really good example of that, for example, is the use of oxytocin to prevent postpartum hemorrhage. When we were doing work with the Better Birth trial, we realized that people were using oxytocin, but they were using it before the woman delivered because they wanted to accelerate delivery. That didn't do anything very good in terms of postpartum hemorrhage. Is it the wrong implementation strategies? So if all I'm doing is putting in place a checklist, but I'm not giving coaching, unlikely that it's going to actually work. With the strategies not implemented well, maybe the coach actually never went to the site, they are his coaching. Was it the wrong population, or were there other things that got in the way that were going to actually help get in your way in terms of starting or scale up, such as, for example, community lack of knowledge or resistance? So all of these can be answered through implementation research. So we're going to start first on frameworks and models, and I'll give you a slight warning. There are now more than 100. So before you start a trial, you can actually spend your entire time thinking about which models or frameworks you want to use. So these are a few that I commonly use. And this was the advice that I got from another implementation researcher who said, I'm a 3-trick pony. I know 3 and I use 3. I probably have about 5 that I use. And so there's not any one that are specifically, I'm just going to go over a couple that are more commonly used. So when you choose it, you can choose among 3 different kinds, and often we use more than one in a study. So the first one are what we call determinant frameworks. And those are things that help you understand what is the context, what are the potential barriers and facilitators you need to know about. And probably the most common one is called CFR, the Consolidated Framework of Implementation Research, but there's other ones as well. But it's really helpful to bucket where you need to be asking questions. The next one is what we call process frameworks, and these are very helpful for getting you organized in the steps that you're going to take to design and do your implementation research, and expanded the EPIS, or Exploration, Preparation, Implementation, Sustainment, is one of the ones that I use. And then finally, the ones that I think we spend the most time thinking about, which we call our evaluation frameworks. And that's sort of trying to plan what are we going to measure and seeing whether or not it worked. And the one I'm going to talk the most about is REAIM, but there's also a lot of other ones as well. So my only advice is choose a few, get to know how to use them, because otherwise you'll spend too much time figuring out which one you want to use. So here's one that this is probably the one that's kind of the broadest one by Proctor. And what you can see is what I like about it is actually starts with either quality improvement or evidence-based intervention. So this can actually be used if you're doing QI. It says, how are you going to get that into place? Your strategies, your implementation outcomes, which I'll talk about later. And then interestingly, what she called service outcomes, but are actually the domains of quality, including things like efficiency and timeliness and equity, and then finally the health outcomes. And we don't always go all the way to the end of implementation research, but it's always good to keep this in mind. So here again, just to remind you, these are the domains of quality. And I would argue that implementation research often doesn't focus on quality as much as it should. So sort of just a plea out to all of you who are involved in clinical is to keep that in mind. And I think that's one of the reasons we put it into the title of this, is that implementation research should focus not just on getting people to do the right thing, but to do it right. And by right, we mean not just in terms of effectiveness, so technical quality, but patient-centered outcomes, timeliness, equitably, safely, and very importantly, efficiently. So when we talk about this evaluative framework, REAIM stands for reach, effectiveness, adoption, implementation, and maintenance. Again, it just helps you figure out what are the questions you want to ask. Who's intended to benefit, and did it actually reach them? Was it effective in the setting in which you actually put it in place? Was it applied? Who applied it? So if I said I'm going to actually make PrEP, I'm going to integrate the pre-exposure prophylaxis into primary care. Are primary care providers actually willing to do that? Implementation is where we talk about things like fidelity, adaptation, acceptability. And then finally, the area which most researchers need to look at, which is maintenance. Because if you do something, is it going to stay in place towards the end of the trial and then after you leave? This is the consolidated framework for implementation, and it's been a little bit adapted since here. I would say it's very, very detailed, and often we just focus on these sort of buckets. And these are the areas where you need to ask. Think about doing the focus group discussion or key informant. What are you asking about? You're asking about, do you like this intervention? Can you do it? What's happening in the inner setting, so in the clinic, for example, in which you're implementing? What about the community attitudes? What about the people that you want to deliver it or receive it? And then finally, the implementation process. What are the steps that you actually need to take? So again, not all of these are going to be relevant, but it's very important to think about it as you're starting to plan. This is another one which I actually really like, because it puts the individual in the center, and then says you need to look not just at the individual patient or individual client, but also all the other things that are going to affect your ability to get the evidence-based practice to them and get them to accept it. So how do you choose your framework? Vendor, there's 100 again. choose a few that you know, ask a friend, look at an article, and then see what are your goals. It's informative work. You're just starting to ask all of these questions about how am I going to go about doing it? Are you actually testing an intervention? Or often I get called in afterwards to say, help me understand why this did or didn't work, did or did not get into practice. None of these are relevant to your work. A lot of these are evolving. Very importantly, a lot of implementation science is actually designed in the US and the UK, and it needs to be adapted for different settings. And also, you can ask around for other ones. For example, sometimes we use the WHO health systems building block, not a traditional implementation research framework, but often very, very helpful. And again, no matter what you choose, the key thing is it helps you get organized. So again, what do we mean by contextual factors? And again, this is the difference between an efficacy or a pure effectiveness trial. So in a pure effectiveness trial, you control very carefully who's enrolled in the trial, where it's actually happening, how well people are coming up. When you go out into the sort of the great wide world, you can't do that so much, especially if you're looking at things that are at a village level, a clinic level, or even a state level. And so there you need to think about what are the barriers and facilitators that can interfere and help. And again, these occur at multiple levels or actually the intervention. And you use these to map your strategies. So keep that in mind when we talk about strategies. Are you going to address barriers? Are you going to leverage facilitators? For example, everybody says, we're going to do training. Well, why are you going to do training? Is it because your providers don't know? Is it because they don't believe in it? If they believe in it and they don't know, but they can't do it because they don't have the equipment, then you need to have a different strategy. And we'll also form plans for scale. And one of these is a really good story that I know from when we were doing Betterberg. So Betterberg was a safe childbirth checklist. And one of the things you're supposed to do is take the temperature of the woman when she comes in labor. And we had one midwife who was never taking the temperature. And so the coach went and said, what's the problem? And she said, well, I don't think it's there's no thermometer here. And there actually was no thermometer there. So there was a contextual barrier. So we got a thermometer. We went back, still not doing temperature. What's the problem? The thermometer is locked up. They didn't want anybody to take the thermometer, which was true. So we got the thermometer to be available. Came back, still wasn't taking the temperature. So, okay, why not? Well, I don't believe that it's important. I think you tell if the person has a fever. So then we did a little bit of training and coaching, different strategy. Came back, still wasn't taking the temperature. So at this point, the coach had a good relationship, and she realized that this was an older midwife, very, very, very knowledgeable. But why do we think that she was not taking the temperature? And I'll give you a big hint. It was an old-fashioned thermometer. She couldn't read it, and she wasn't willing to say that that was the barrier. And all it really needed was a pair of reading glasses. So you need to always understand your barriers. You need to make your first guesses, and then you need to adapt your strategies. So this is a really important one. Just another illustrative example. This was a study that was done in India to look at quality improvement to improve care for patients with heart attacks. And what they found is it was a null study. It didn't actually work. But in a certain percentage of them, actually, the facilities got a little worse, but actually a number of them, they got better. What we call positive outliers. And so those 25%, the question was, why did it work in those 25%? And it turned out it was really due to contextual factors. Because it turns out that actually, if you have physician-supported leadership, if they think it's easy to use, they have staff training, they're willing to actually do the quality improvement, it would work. And in the hospitals which had the negative effect, there was issues, including they didn't understand the toolkit, they didn't have internet access, and they were very busy. So, and it turned out actually that management also made a difference. So you need to understand not only when you're doing it, but afterwards. Variability is something that clinical trials people hate. Implementation researchers love because it often gives us the answers of how to do it better next time. So now I've talked a little bit about the strategy. So again, remember, these are all the things we do to get people to do the intervention. Take the temperature, give the oxytocin, put the baby on CPAP, screen older people for cognitive impairment. So Another story I'm going to tell you about why implementation strategy works. So I worked for Dr. Gowande for 4 years, which is why I talk a lot about checklists. He's the person who helped design the safe surgical checklist, safe childbirth checklist. Anybody here used either of them? I'm assuming as much. So this is about the safe surgical checklist. And this was designed with the World Health Organization. There's nothing new on here. These are all the things you're supposed to do. You know, make sure that you're operating on the right side, make sure everybody knows who they are, make sure you have the right equipment, make sure you have the right sponge can at the end, etc. So this was studied in a number of different, very diverse settings, so all the way from Tanzania to Seattle. And they found to everybody's really delight and to some extent surprise that not only did it work, it actually saved lives. And people were really excited. They thought, this is great. We have a checklist. We just give it to people and it will save lives. So this was done in Ontario, Canada. And guess what happened? Nothing happened. This is a strategy that a colleague of mine calls, wasn't quite that simple, but print and plot. So just print it out and give it to people. And so when they went back and they actually sort of really understood what had happened in the trial, there were these research assistants who were actually surgical residents who were probably providing practice facilitation and coaching. Oh, I noticed that you're not moving the antibiotics. Maybe you should bring the antibiotics into the emergency room, into the operating room. Don't forget to actually use the checklist. And so when this was done again in South Carolina with all of these strategies, it actually worked again. And that's been shown in a number of things. And they actually found that there was about 10 different embedded strategies, including leadership engagement, making certain surgeons understood what to do, et cetera. And when people did all those things, it actually saved lives again. So the strategy matters as well as the intervention that you're putting into place. Now, often choosing strategies is very haphazard. Has anybody heard this acronym before? It's lucky out. It seemed like a good idea at the time. That's probably not a good way of choosing your strategy. So there's actually other ways of doing it. The first, again, is understanding your context. So if I'm implementing the COVID vaccine in Chicago versus, for example, in Lagos, or another place I do a lot of work in Rwanda, I need to understand all of these things. I need to understand out the intervention. Okay, it needs minus 70 degrees. Is there a cold chain that's actually able to do that to get to everybody who needs it? How am I going to get it there? And how's the supply chain? You know, can I just go down the street to the pharmacy and will they have it? Who's going to actually implement it and who's going to give the vaccine? And then very importantly, this is something that we did not do very well in the US, is understand who are the opinion leaders and what do we need to do to actually get community engagement to actually take the vaccine. So context matters, so we need to choose and adapt the strategies that make sense. Now, again, this rarely one-to-one. Often we do many things. Remember the midwife of taking the temperature to actually get to that. And often you can actually address more than one barrier with them. So here's some examples of what we call discrete strategies. One strategy addressing one problem. Lack of knowledge, we might do training or simulation, other kinds of interventions. Slow implementation, we might get audit and feedback. You're doing okay, but did you know that your other clinics are doing much better than you? We often do that little competition. Lack of motivation, sometimes we use incentives or audit and feedback. And very importantly, beliefs or attitude to the intervention. You know, can you get your opinion leaders? But again, often it takes more than one. This is an example from trying to get a cervical cancer screening. And what's important here is realizing the strategy should not just focus on the health system and the provider, but also what we call the demand side. So for the individual. So for example, if we talk about, we're worried about provider communication, we want to do education and counseling, we want to actually get the health systems to work together and learn from each other. This will drive physician motivation and skills, women's knowledge, will improve the provider-patient interaction, and will increase cervical cancer screening, both the acceptability from the women's perspective and the adoption. So again, thinking about this is how you actually design. So where do you look for strategies? There's a lot of them. This is a group of them called ERIC that was developed, again, mostly in the US. So there's often a number that are missing here, but it's not a bad starting place. They've been sort of also done into these sort of 6 buckets. where you can sort of say, do I need one in each of these buckets? Sometimes yes, sometimes not. Policy context is really, really important. We were just sort of talking about long-acting pre-exposure prophylaxis for HIV. There has to be policies put in place that that's actually going to be supplied and how it's going to be done. You can look at the literature. Who else has done it? You can ask other implementers who maybe been successful, and very, very importantly, ask the community and the people you're engaging, because often they have the answer in terms of how you're going to actually change opinion, how are you going to actually get uptake of what you think is a good idea. The other thing which people hate to do is to detail your strategy. So when I started to do the Better Birth trial, people said, we were doing coaching. Oh, that's great. We had 5 coaches. I said, how are you doing it? I got 5 different definitions of how they were doing it, how often they were doing it. And in a randomized clinical trial, you've got to know what the coaches are doing. And if you want to scale, you need to also know. So Proctor came up with this idea about how you specify your strategy, and these are all the different components that you need to do. So here's an example. So we want to do training to address the gap in knowledge and competence of community health workers, actually choose to manage hypertension. This is from a study we're doing with the University of Abuja with Dr. DK Oji. So the training will be done through in-person sessions for community health workers to deliver hypertension care. It will be done by experts at the hospital, and we'll be targeting choose at the primary health care. It'll be done at the start of the study and at 1 year. We'll do a 2-day training at the start and a 1-day refresher. We're targeting adoption and fidelity, and this is the justification of why we're doing it. So if somebody else wants to do the same thing, they're going to know exactly what we did. Now, we also have the curriculum, but this is a really important stage that most researchers hate to do because it actually takes time. So now that we've figured out what are our barriers and facilitators, we figured out what we want to do, the strategies to actually address the barriers or leverage our facilitators. Now we're at the point of the implementation outcomes. So these are some very sort of technical terminology about some of these outcomes that we measure. So for example, fidelity, very much like quality, is what is the intervention to implement it as designed versus feasibility, which means could you actually even do it? So for example, if you decide that what you want to do is you want to give people physical exams every year. You want to know, could they do physical exams? But fidelity says, did you actually do what you needed to do in a physical exam? Take the PPE, ask about smoking, all the other things we're supposed to do. Acceptability, are people even willing to come in and get a physical exam? And adoption, are the providers actually being willing and are they actually doing physical exams? Now, this is really important because if you start with something that's very effective, so this is a 94% effective intervention, the vaccine, also the original COVID vaccine. And we ask, okay, 94%, but if 80% of your clinics are actually willing to give the vaccine, and 80% of the providers are giving it correctly, they're giving the right dose, they're keeping it at the right temperature, and 80% of the population is willing to actually take it, and 80% of your clinics will keep on doing it over a year, your effectiveness is not 80%, it's actually 38%. And even more concerning when you talk about equity is if you drop that down to 50%, you have about a 6% population benefit. So the work is not done just because we have an effective vaccine. It's really, again, how do we get it to everybody everywhere correctly? Now, we can link this all together. And this is something called an implementation research logic model. Don't expect anybody to remember this at the end of this, but if you have questions, just talk to me about it. But the idea is that we sort of try to bring together, so here's all your barriers and facilitators, we call them determinants sometimes. This is CFR, but other things can go there as well. We then say, okay, we have implementation strategies and the mechanisms. Again, why are we doing training? Why are we doing audit and feedback? It's meant to also then to put these into the evidence-based intervention into practice. And then we flipped over these outcomes on the side, implementation outcomes, quality wellness intervention that we were adapting to try to act working and avoid burnout. And so what was done was, again, looking at what were some of the determinants, the things that are positive. We knew it was effective, we knew we could adapt it. But some of the negative settings, the things that were going to get in our way was low staffing levels, staff turnover. And so all of those then informed the implementation strategies that we then said, this is why we're going to be doing these things. And again, this is what we guessed at in the beginning and had to undergo. So the implementation research logic model, your strategy will evolve over time. But that's part of the learning that's going on. So that at the end, if another city wants to take this up, we'll know what needs to be adapted. So talking about quality and quality improvement and quality outcomes, how does all this come together to help you improve quality? And again, I think the thing is, it gets you to think a little bit beyond the people in the facility, which is really where quality improvement has traditionally lived. It helps you, I think, better understand the gaps in the facilitators to better design those things, looking at policy and systems, facilities, staff. So for those of you who might have done what we call the Ishikawa diagram or fishbone, anybody here ever done one of those for root cause analysis? Yep. So you'll see some of the similar things, but it goes a little bit beyond that. And the idea is, again, it should accelerate change locally, but also more broadly. Because if we want to try to improve, again, sort of thinking about some of the work I'm doing with university in neonatal mortality, if we try to improve one thing at a time, one facility at a time, like we're just talking 2030 until we actually fix things. And the other problem is that there's a game that's called whack-a-mole. So it's a game that you do like in fairs in the US. And the idea is that you have these little moles, which are sort of things that live underground, they eat your flowers, and they pop up in these holes. And in the game, not real, this mechanism, you have one pop up and you whack it down, and another one pops up, and you whack it down, and the old one pops up. So all we're doing is one thing at a time. These problems are never going to be solved, and we're not going to learn from each other. And that's where implementation research can really help. So we can borrow, again, frameworks from other areas. This is from the Atlantic Commission on High Quality Health System. Your current Minister of Health was actually one of the two lead commissioners on it. I learned an enormous amount from him. But again, the idea is that we're looking sort of at some of these foundational areas where implementation research strategies can help us strengthen to ultimately get to where we need, which is better health, more trust and confidence, and economic benefit, which ultimately is, I think, the goal that we all have. There's other ways of bringing these two things together. The model for improvement is something that's very commonly used in quality improvement. What do we want to accomplish? How do we know what changes in improvement and what changed? And you can actually link it to implementation questions. So for those of you that do quality improvement and are interested in learning about implementation research, happy to have that conversation. It's a really important one to have because, again, it will accelerate the change that's needed. Now, just sort of one last thing about how do we actually then test whether or not these strategies are the right ones and helping us get to where we need to be. And we do what are called hybrid designs, but I know there's a number of them that are already underway here. But again, if we start with a type 1, that's where we have something that's effective, we're kind of sure, but we want to still make sure that it's effective. But we also want to be looking at the implementation strategies. Now, it doesn't have to necessarily be an outcome like death or decreased disability. It can also be things like patient-reported outcomes, pain, quality of life. If we're sort of 50-50, we're kind of interested in both, we go to a hybrid type 2. And if we still want to know a little bit about effectiveness, but we mostly want to invest in understanding our strategies, we go to a hybrid type 3. And if you really know, so again, one is test the thing, but gather some information on doing the thing. Type 2 is you testing the thing and testing whether you're doing the thing right. And type 3 is you're really testing the strategy, and then but you're gathering some information on effectiveness. So if you're thinking about power or sample size, if you're writing a grant, again, hybrid type 2, you need 2 primary outcomes. Type 3, your strategy drives your power and your sample size. Type 1, your effectiveness does. Just a little aside as you write your grants. So how do we bridge this gap? And I've lived probably most of my life in this gap, knowledge and evidence into practice, and what I call the do, practice, and quality gap. So getting people who are doing it to do it right. But I say we really need to collaborate, and I've learned a lot from people in in other areas about health policy research. We need to get the knowledge and evidence into policy because that's sustainability. So if I do a project that works, but there's no policy that's actually adopted to actually implement this. So if there's no way, so we're doing this work with community health extension workers to treat hypertension. There had to be a policy change, which there is now, which actually allows task sharing, and therefore that's for sustainability. But we also know that just because something's in policy doesn't mean it gets into practice. And that again is another place where stakeholder engagement, as well as embedded implementation research, training the implementers, training the policymakers to actually get this so that we can actually complete this triangle as well as not forgetting the practice, the quality gap. So in conclusion, and there are many, that we need to really ensure both access and quality. And if we really want to meet the health-related SDGs and universal health coverage, we absolutely have to do this. But ignoring how to better design how we implement and how to accelerate spread is not going to get us where we need to go. And so we need to actually take a look at the things that are have not in 20, 30 years ago, were not traditionally part of research. And when I started doing implementation research, somebody said, that's not really research what you're doing. That's okay. It's still, we call it evaluation until you call it research. And now it's called research. Implementation research, I will argue, will give you those tools about how to actually do this to really bridge those gaps, both the policy to practice, evidence to practice, and the quality gap. But it has to really evolve. So implementation researchers are guilty of using jargon and not really talking to the people that we need, who needs to be the uptake of the evidence that we're producing. So the success of implementation research is not just, or really should be much more than the publication in the high impact journal. Because high impact journal is defined by who reads the journal. It's not actually defined by the impact of the paper. And so we need to really think carefully about who we are training in implementation research, who we are getting to actually demand, and who we ask, what are the questions that need to be asked. There's a lot of other work that's needed in implementation research that includes a better understanding of how do we improve equity and equality, capacity building, and very importantly, de-implementation. Getting people to stop doing what doesn't work is probably as difficult or more difficult than getting people to start doing something new. And so those are challenges that are ahead. I'm really excited about some of the work that is happening in the center and also some of your plans for capacity building in implementation research. And so this is just starting. Join the movement, whether it's through your center or through other areas. And really, thank you all so very much for inviting me on this.